The objectives for this lecture are as follows. Review the current muscle relaxants used, review the physiology and metabolism of muscle relaxants, and explain how to appropriately interpret patient recovery from neuromuscular blockade. Skeletal muscle relaxation can be produced by deep inhalational anesthesia, regional nerve blocks, or neuromuscular blocking agents. Let's review a little history. In 1942, Griffith and Johnson suggested that D-tubocurarine, or DTC, was a safe drug to use during surgery to provide skeletal muscle relaxation. 1 year later, Cullen described its use in 131 patients who had received general anesthesia for their surgery. In 1954, Beecher and Todd reported a 6-fold increase in mortality in patients receiving DTC versus those who had not received a relaxant. The increased mortality was due to a general lack of understanding of the pharmacology of neuromuscular blockers and their antagonism. The impact of residual neuromuscular blockade postoperatively was not appreciated. Guidelines for monitoring muscle strength had not been established, and the importance of pharmacologically antagonizing residual blockade was not understood. Since then, the understanding of neuromuscular blocker pharmacology has improved, and relaxants have become an important component of many anesthetics and have facilitated the growth of surgery into new areas with the use of innovative techniques. Let's start with a brief anatomy review. All neuromuscular blocking drugs act by antagonizing the action of acetylcholine at the nerve muscle synapse, also commonly referred to as a neuromuscular junction. The region of approximation between a motor neuron and a muscle cell is the neuromuscular junction. As a nerve's action potential depolarizes its terminal, an influx of calcium ions through voltage-gated calcium channels into the nerve cytoplasm allows storage vesicles to fuse with the terminal membrane and release their contents of acetylcholine. The acetylcholine molecules diffuse across the synaptic cleft to bind with nicotinic cholinergic receptors on the motor end plate of the muscle membrane. The structure of acetylcholine receptors varies in different tissues and at different times in development. Each acetylcholine receptor in the neuromuscular juncture normally consists of 5 protein subunits. The 2 identical alpha subunits are capable of binding acetylcholine molecules. If both binding sites are occupied by acetylcholine, a conformational change in the subunits briefly opens an ion channel in the core of the receptor. The channel will not open if acetylcholine is only on one site. Sodium and calcium flow into the cell and potassium out, and an end-plate potential is generated. When enough receptors are occupied by acetylcholine, the end-plate potential will be sufficiently strong enough to depolarize the perijunctional membrane. The resulting action potential propagates along the muscle membrane, opening sodium channels and releasing calcium from the sarcoplasmic reticulum. This intracellular calcium allows the contractile proteins actin and myosin to interact, bringing about a muscle contraction. The amount of acetylcholine usually released and the number of receptors subsequently activated normally far exceeds the minimum required for the initiation of an action potential. Neuromuscular blocking agents are divided into 2 classes, depolarizing and non-depolarizing. Similar to acetylcholine, all neuromuscular blocking agents are quaternary ammonium compounds whose positively charged nitrogen imparts an affinity to nicotinic acetylcholine receptors. Depolarizing muscle relaxants act by actually binding to the acetylcholine receptors and blocking access to these receptors. In the process of binding, the receptor is actually activated, causing a process called depolarization. Unlike acetylcholine, however, these drugs are not metabolized by acetylcholinesterase, and their concentration in the synaptic cleft does not fall rapidly, resulting in a prolonged depolarization of the muscle end plate. Continuous end plate depolarization causes muscle relaxation because opening of the lower gate in the perijunctional sodium channels is time limited. After the initial excitation and opening, these sodium channels close and cannot reopen until the end plate repolarizes. The end plate cannot repolarize as long as the depolarizing muscle relaxant continues to bind to the acetylcholine receptors. This is called a phase 1 block. After a period of time, prolonged end plate depolarization can cause ionic and conformational changes in the acetylcholine receptor that result in a phase 2 block. which clinically resembles that of non-depolarizing muscle relaxants. Succinylcholine is the only therapeutically useful neuromuscular blocker that is used by anesthetists clinically. Succinylcholine is composed of two molecules of acetylcholine linked back-to-back through the acetate methyl groups. Like acetylcholine, succinylcholine stimulates cholinergic receptors at the neuromuscular junction and at nicotinic and muscarinic autonomic sites to open the ionic channel in the acetylcholine receptor. The onset of paralysis by succinylcholine is usually signaled by visible motor unit contractions called fasciculations. These can be prevented by pretreatment with a small dose of a non-depolarizing relaxant. Because this pretreatment usually antagonizes a depolarizing block, a higher dose of succinylcholine is subsequently required. The usual adult dose of sux needed for intubation is 1 to 1.5 milligrams per kilogram for acceptable intubating conditions if a defasciculating dose of a non-depolarizer is not used. Because succinylcholine is not lipid-soluble, its distribution is limited to the extracellular space. Per kilogram, infants and neonates have a larger extracellular space than adults. Therefore, dosage requirements for pediatric patients are often greater than for adults. If succinylcholine is administered IM to children, a dose as high as 4 to 5 milligrams per kilogram does not always produce complete paralysis. Sux should be stored under refrigeration and should be used within 14 days after removal from refrigeration and exposure to room temperature. Patients who have received succinylcholine have an increased incidence of postoperative myalgias. The myalgias are theorized to be due to the initial unsynchronized contraction of the muscle groups. The complaint is most common in females. Pregnancy and extremes of age seem to be protective. The efficacy of non-depolarizing pretreatment, such as ROC 0.1 milligrams per kilogram, is controversial, but most clinicians feel it is effective. Perioperative use of nonsteroidal anti-inflammatory drugs may reduce the incidence and severity of myalgias. Extraocular muscle differs from other striated muscle in that it has multiple motor end plates on each cell. Prolonged membrane depolarization and contraction of extraocular muscles following the administration of succinylcholine transiently raises intraocular pressure and could compromise an injured eye. Succinylcholine transiently increases muscle tone in the masseter muscles. Some difficulty may initially be encountered in opening the mouth because of incomplete relaxation of the jaw. A marked increase in tone preventing laryngoscopy is abnormal and may be a premonitory sign of malignant hyperthermia. The elevation in intraocular pressure is not always prevented by pretreatment with a non-depolarizer. Despite the fear that a patient will have some condition that causes acetylcholinesterase deficiency, it has been demonstrated. Despite the fear that a patient will have some condition that causes Despite the fear that a patient will have some Despite the fear that Despite the fear that a patient will have some condition that causes Despite the fear that a patient will have some condition Despite the fear that a patient The DiBK number is proportional to acetylcholinesterase function and independent of the amount of enzyme. 1 out of 480 patients have one normal and one abnormal acetylcholinesterase gene, resulting in a slightly prolonged block, around 20 to 30 minutes. Even fewer, 1 in 3,200 patients, have two abnormal genes that produce an enzyme with little or no affinity for succinylcholine. In contrast to the doubling or tripling of the blockade duration seen in patients with low enzyme levels or heterozygous atypical enzymes, patients with homozygous atypical enzymes will have a very long blockade if given sux. Prolonged paralysis from succinylcholine caused by abnormal acetylcholinesterase should be treated with continued mechanical ventilation until muscle function returns to normal. In contrast to depolarizing muscle relaxants, there is a wide selection of non-depolarizers. Chemically, they are categorized as either benzoyl-isoquinolones or aminosteroidal compounds. Choice of a particular drug depends on its unique characteristics, which are often related to its structure. For example, aminosteroid compounds tend to be vagolytic, whereas benzoyl-isoquinolones tend to be histamine-releasing. Because of structural similarities, if your patient has an allergy history to one muscle relaxant, this strongly suggests a possibility of allergic reactions to other muscle relaxants in that group. Non-depolarizing agents are not significantly metabolized by either acetylcholinesterase or pseudocholinesterase. Reversal of their blockade depends largely on redistribution, gradual metabolism, excretion of the relaxant by the body, or the administration of specific reversal agents called cholinesterase inhibitors that inhibit the acetylcholinesterase enzyme activity. None of the current non-depolarizers equals succinylcholine's rapid onset of action or short duration. However, the onset of non-depolarizers can be quickened by either using a larger dose or a priming dose. To prevent fasciculations, 10 to 15% of a non-depolarizer intubating dose can be administered 5 minutes prior to succinylcholine. Because of the antagonism between most non-depolarizers and a phase 1 block, the subsequent dose of sux should be raised to 1.5 milligrams per kilogram. Following intubation, muscle paralysis may need to be monitored to facilitate surgery or anesthetic management. Monitoring neuromuscular function with a nerve stimulator helps prevent over- and underdosing, as well as serious residual muscle paralysis in the recovery room. Maintenance doses should be guided by the nerve stimulator and clinical signs. In some instances, clinical signs may precede twitch recovery because of differing sensitivities to muscle relaxants between muscle groups or technical problems with the nerve stimulator. Some return of neuromuscular transmission should be evident prior to administering each maintenance dose. Vecuronium is pancuronium minus a quaternary methyl group. This minor structural change beneficially alters side effects without affecting its potency. Vecuronium is metabolized to a small extent by the liver. It depends primarily on biliary excretion and secondarily on renal excretion. Vecuronium is equipotent to pancuronium, and the intubating dose is 0.08 to 0.12 mg per kilogram, providing adequate muscle relaxant within 2 to 3 minutes. Women appear to be approximately 30% more sensitive than men to vecuronium, as evidenced by a greater degree of blockade and a longer duration of action. Vecuronium is packaged as 10 mg of powder, which is reconstituted with 5 to 10 ml of preservative-free water immediately before use. Unused portions are discarded after 24 hours. Even at high doses, vecuronium is devoid of significant cardiovascular effects, but potentiation of opioid-induced bradycardia has been described in the literature. This slide describes dosing guidelines and pharmacodynamic parameters of neuromuscular blocking agents. The following slides describe significant interactions with neuromuscular blocking agents. Certain illnesses, both those confined to the neuromuscular junction and those affecting more general systems, dramatically affect the use and safety of neuromuscular blockers. Generally, transmission at the neuromuscular juncture is abnormal in these disorders, and there are ultra-structural and biochemical changes in motor nerves, muscle, or both. The first disorder that we will discuss is burns and prolonged immobilization. These include thermal injuries affecting fluid and electrolyte regulation, cardiovascular and pulmonary function, drug metabolism, and musculoskeletal structures and function. Burn patients and many immobilized patients, such as those found in the ICU, have a greatly exaggerated response to depolarizing agents and a decreased responsiveness to non-depolarizers. Burn patients exhibit ultrastructural and biochemical alterations in both muscle cells and neuromuscular contacts. Administration of succinylcholine can cause dramatic and sometimes fatal hyperkalemia. These effects can be seen for greater than 1 year after the initial thermal insult. Similar problems have been reported in patients who have sustained major crush injuries or large areas of devitalized tissue. The diagnosis is supported by the clinical history and confirmed by transiently improved muscle strength after 10 mg of IV etrophonium, the Tensilon test, by characteristic electromyographic findings, and most specifically by the presence of anti-acetylcholine receptor antibodies in the patient's serum. Treatment includes anticholinesterase, corticosteroids, immunosuppressive drugs, plasmapheresis, and thymectomy. Remission of the disease is common after thymectomy. Special attention needs to be given to myasthenia gravis patients receiving either regional or general anesthetic. The use of neuraxial regional anesthesia is associated with skeletal muscle relaxation and some degree of diaphragmatic weakness. This normal effect of regional anesthesia often unmasks underlying weakness that may have been only partially treated by cholinesterase inhibitors. These patients, therefore, may suffer from profound respiratory weakness even when not challenged with neuromuscular blocking agents. They need careful respiratory monitoring throughout anesthesia and recovery. Anticholinesterase therapy should not be discontinued before surgery. By the preteen years, the patient often is confined to a wheelchair, and death usually occurs by the mid-20s secondary to congestive heart failure. Serum creatinine kinase levels are elevated and track the progression of muscular degeneration. Although the diaphragm is spared, accessory muscle weakness produces a restricted pattern on pulmonary function testing. Because coughing is impaired, pneumonia is a frequent complication. Succinylcholine can cause rapid rhabdomyolysis, hyperkalemia, and death. Studies involving non-depolarizing neuromuscular blockers exhibit variable results. Because the intensity and duration of drug effect is hard to predict, short-acting agents may be preferable. Volatile inhalational agents, particularly halothane, can have exaggerated myocardial depressant effects. Malignant hyperthermia occurs with increased frequency, but there are no good predictive tests for which patients are at risk. The delayed gastric emptying and ineffective cough place these patients at greater risk for regurgitation and aspiration. Postoperatively, these patients require aggressive pulmonary physiotherapy to ensure adequate secretion clearance. Opioids, which may further depress deep breathing and coughing, should be used cautiously. So let's look at what the future may have in store for us. The management of patients given neuromuscular blocking agents is often less than ideal, and available management options should be improved. Cholinesterase inhibitors are the only drugs available in the U.S. to pharmacologically reverse neuromuscular blockade. Cholinesterase inhibitors reverse neuromuscular blocking agents indirectly by increasing acetylcholine to compete to binding to the nicotinic acetylcholine receptor. One of the main limitations of cholinesterase inhibitors is their inability to reliably produce a train-of-4 ratio greater than 0.9 within 30 minutes of administration, regardless of the train-of-4 count when the agent was given. Currently, there are several methods by which the effects of neuromuscular blockers can be ended. Physiologically, some agents are metabolized through common pharmacokinetic pathways that result in their elimination, while some are excreted unchanged. Inactivation can also occur by ester hydrolysis or spontaneous degradation or Hofmann elimination, as occurs with cisatracurium. Direct encapsulation is another novel approach to reversing neuromuscular blockers. The selective relaxing binding agent sugammadex is the first in class using this approach. Since its first approval in the European Union in 2008, sugammadex has been approved in more than 50 countries worldwide for the reversal of neuromuscular blockade. However, it has yet to gain approval from the U.S. FDA. Demodex was suggested as a possible rescue drug to be used in can't intubate, can't ventilate situations. In conclusion, throughout the history of the basic and clinical sciences in which surgical relaxation has been studied, neuromuscular blockade is now our most commonly employed option. Ideal circumstances have been envisioned and foreseen. The ideal situation might simply be conceptualized as the ability to induce or remove neuromuscular blockade rapidly and safely at any time, without concern for negative outcome. The clinician's view of the utility of a neuromuscular blocking drug most likely involved 4 considerations. What are the onset of effect, the duration of effect, the side effects, and the reversibility of the drug in question. These factors underlie the clinician's feelings of convenience, confidence, suitability, and versatility in the application of a specific neuromuscular blocking drug in a particular procedure. It still all resolves to one fundamental issue, which, after all, is the underlying guideline in anesthetic practice: safety, as related to outcome. Drug developers may improve the safety of neuromuscular blocking drugs with respect to clinical practice by improving the above clinical features, so that the practitioner can make more appropriate choices for neuromuscular blockade and so feel more confident and versatile in terms of safe practice and reduced negative outcomes. Now we will review some key concepts covered and applicable to this lecture.